tonight's presenter is our very own Dr. Charles Metzger, MD. And we were going to talk about something called the National Comprehensive Cancer Network Guidelines for Prostate Cancer and what's new. And we're going to say, what's the National Comprehensive Cancer Network? And why is all this important? The National Comprehensive Cancer Network Guidelines incorporate real-time updates in keeping up with the rapid advancements in the field of prostate cancer research and management. NCCN guidelines help people with prostate cancer talk to their doctors about the best treatment options for their disease. And as you know, if you've been with us any length of time, things are changing at a rapid pace. Dr. Metzger is a retired urologist who's practiced in Glendora for over 30 years. He's a frequent contributor of newsletters to the Prostate Forum website and co-leader of our support groups. He received his medical degree at Emory University School of Medicine in 1972, and also has an MBA in healthcare financing from UC Irvine. And as we discussed, and maybe you didn't catch it, he did his internship or residency at the University of Southern California, Los Angeles County Medical Center downtown. His special interests include the use of guidelines for providing medical services. I'm going to stop talking now, and without further ado, turn this over to Dr. Charles Metzger.
No, thank you, Neil. That sounds make me tired just listening to that. We have been listening over the weeks and months now, a couple of years, to men come on at the beginning of their journey, during their journey, toward the end of their journey. And one of the things that is the most confusing is men that come on and they haven't had a proper workup. They haven't had the test in the sequence that they need. And it's frustrating for the patients. It's frustrating for the men and their families. It's frustrating for us because we're basically saying, well, you should get this or that. Well, they really ought to have already had this and that. So I thought it would be good, since we're filling in and have a whole hour to fill, to talk about what the National Comprehensive Cancer Network suggests. And this is the #1 cancer network that gives out guidelines. This is what most of the HMOs and health plans blame for why they don't do things. Recently, they came under a lot of pressure because they were about 2 years behind in what should be done. And so they got together and they updated the guidelines. And so the HMOs, Medi-Cal, any of the PPOs, regular Medicare, really have no leg to stand on by not doing a proper workup for our fellas. And when one has to appeal whether or not they can have a certain scan, you just have to refer to these guidelines, and pretty much they're held to them. I didn't make a slide out of it, but I'm holding in my hand a list in the New England Journal. There's 18 different guidelines nationally. It's just more than you can imagine, and none of them agree. There isn't a one of them on here that agrees about anything. So what that does is that means there's a lot of confusion and disarray in the entire industry on what is appropriate. You'd think the American Urologic Association would have a lock on it, but they approach it according to the fee-for-service aspects, not necessarily what's best or what proves to be the best way to go, but they have a bent to what's best for the individual practitioner. Whereas the U.S. Preventative Services Task Force is the other way around. They tend to be non-urologic people. They tend to be more internist and family people, and they don't want to do digital rectal exams. They don't want to do PSAs. They don't want to take 15 minutes to do patient explanations. And so they slant their guidelines. Now, you'd think if something as important as this, they could put all that aside and just do what's right. So I think the revision in the National Comprehensive Cancer Network is probably the best of all of them. It's a very prestigious group. Interestingly enough, several local standout hospitals, medical centers are not involved. I won't mention which ones because I don't want to color anyone's opinion of them, but we only have 2 of the 4 local standout centers that are actually in this network, which is very interesting. Almost every health plan now, including Kaiser, is starting to approve things according to these guidelines. So let's go over some of these guidelines. The main issue that they all say is why it's so confusing is because the spectrum of disease is so great. I see pictures on the side of some people listening to this. Each one of you in your own individual way has your own situation, and the disease can be a wide spectrum. It's a cancer, yet 70% of the men diagnosed don't need treatment. Now, we didn't know that 10 years ago. We didn't know that 8 years ago. And so we treated everyone. And it turns out we overtreated a lot of men that just didn't need it. They could be watched and waited on. And they used to call it watchful waiting. They now call it active surveillance. It has different names in Europe. The goal of the guidelines is to help the guy that's out in the practice know what's the appropriate up-to-date thing to do. Probably the biggest change besides PSMA, which is a topic for another talk, is the MRI and the role it plays in what we're doing. And the MRI is expensive, and yet it really dictates what gets done and should dictate what gets done. It is one of the few things that the European urologic group and the American group can agree on, is that everyone should consider or have an MRI. We're seeing Kaiser now doing it a lot more. HealthNet is doing it more, and it's starting to be part of the fabric of the workup. And the reason that the MRI is done is because the literature is full of guidelines or of articles that show an MRI fused targeted biopsy will help eliminate some of the unnecessary Gleason score prostate cancer and only diagnose the ones that really need treatment, the grade group 3 through 5. The other big change, especially in Europe, and it's now a recommendation, is changing from the transrectal biopsy to the transperineal biopsy. And the perineum is the area between the scrotum and the anus. It's an area that's exactly in line with where the prostate is. So you get to do a biopsy, you end up going from front to back in a linear way rather than the transrectal, which goes up and across, and you're more apt to get a full view of what the prostate pathology is. It also has almost no infection associated with it, whereas transrectal biopsies have a 2 to 3, sometimes as high as 5% infection and rectal bleeding. So a lot of the hesitancy to do transperineal is it takes longer, it takes more local anesthetic, it can be done under general anesthetic or sedation, but it has so much better chance of making a diagnosis, especially when fused with the ultrasound. So you put the ultrasound probe in, the software is already fused together. So the MRI tells the ultrasound software where to biopsy. And so you do the targeted biopsies. There are plenty of studies that show doing additional segmental biopsies that are not targeted actually don't add much to the process. So these are the big changes. And certainly the main recommendation is active surveillance for almost 60% of people that are diagnosed. Now, active surveillance doesn't mean you go home and forget about it. It means PSAs quite frequently. It means repeat biopsies if the PSA changes. It means repeating the MRI every couple of years with or without more targeted biopsies. And it is a very active surveillance. But the plan started in Canada, and Larry Klotz was the Canadian urologist that decided this was time to quit over-treating people. And just last week, the 15-year study from the UK was published. And for most of us, it was an eye-opener, because almost everybody in that 20,000 men had low-grade cancer. And most of those men would have done very well with active surveillance. But what they did was they just split them into 3 groups. And they did radical prostates on a third of them. They did radiation on a third, and they did active surveillance on a third. And they now have the 15-year outcomes. And there isn't really any statistical difference in any of the groups, which is shocking, because 20% of the men in the surgery group had to wear a pad. Well, if they'd have been left on active surveillance, they wouldn't have had to have that side effect. 12% of the men with radiation, because in Britain they're using an older radiation technique, had rectal bleeding and rectal issues. Those men would not have had those had they just been on active surveillance. So it turns out it's really a well-done study, which just proves that active surveillance is a very, very good way to go. Just as a matter of advertisement, tomorrow there's going to be the fellow from Johns Hopkins, Epstein, is going to do a talk. And I hope we can get that up in the chat room. So if anyone's interested in hearing it from the horse's mouth, this is a man that's done more second opinion pathology reports than anybody in the country. And it's important because he downgrades a lot of the cancers. And men that thought they were in Gleason grade group 3 and might need to have treatment were downgraded to Gleason grade group 2, which is active surveillance country. The issues of anxiety about active surveillance have to be addressed, but treating that anxiety with a radical prostatectomy is no answer. Treating the anxiety of active surveillance with radiation is not necessarily a good trade-off. So it's very, very interesting that these studies are coming out at the present time. What happened to the PSA? Well, as everybody knows, PSA has been around since the 80s, and the US Preventative Service Task Force said, don't do them. You're diagnosing too many men that don't need treatment. Too many men are being inappropriately treated. Now let's just quit doing it. Well, unfortunately, that means that in the current state of affairs, more men are being diagnosed at an advanced stage. And that's probably not the intent. They were just saying we're trying to protect the men from being overtreated. Some of the other agencies that I mentioned are now doing PSAs, and it's interesting how they decided to do the PSAs. They don't agree on when to start or when to stop. They don't agree on how many to do, but they do agree after a very informed consent about the risk of overdoing it, that men should decide themselves whether they need a PSA or not. If you have a family history, if you're in an age group that's more apt to have prostate cancer, then of course it's an easier thing to say yes to. They decided at age 76, men did not need to have PSAs anymore, because in that group from 76 on, the chance of a new prostate cancer that is serious is very, very low and doesn't justify the expense. So they had to come to a balance between maximizing aggressive evaluation and cancer detection and minimizing the over testing and over treatment. I think when I was in practice, we were doing 8 to 10 biopsies a month, and I would guess over 80% of them came back no evidence of cancer. And some of them came back Gleason grade 3 that didn't need treatment, and some of them came back, we actually found something. Most of the men that were in trouble had a PSA that was over 10, and it wasn't difficult to figure out they needed to be biopsied. So I think the fact is the PSA, lack of PSA has led to more men with advanced disease. On the other hand, it certainly has changed whether you do an operation on somebody that really doesn't need it. Digital rectal exam, the group that were non-urologists decided they didn't like doing DREs. They couldn't decide whether they were really how to do them very well. They weren't well trained. A lot of them thought they should be left to a recreational situation, and a lot of them just don't like to do them. But yet the DRE does add to the chance of getting a positive biopsy by almost 15%. So all of the other agencies besides the Armed Forces group have continued to say digital rectal exam is a good thing to do. And if it done properly, it shouldn't hurt. If done properly, it doesn't add much except a pair of gloves and some KY gel. The HMOs quickly caught on to this. Of course, their idea was to, if you needed a second opinion, was just to use 2 fingers. Well, as you can tell, that's not the way that most people feel about this. The AUA and the NCCN definitely recommend yearly exams. What is really interesting with all these studies, especially the 15-year UK study with it had like an 88% follow-up, is that if you had a PSA less than 1 at age 60, you could probably forget doing PSAs and forget about prostate cancer. There was a very small group of men at age 60 with less than 1 that actually went on to develop disease. So it's probably okay for that group to selectively not have the PSA done, save the money. They couldn't decide whether they still needed a DRE, but I would guess on their yearly exams that they're probably still getting the digital rectal exam. Now, primary care internal medicine doctors are just not trained well to do this, and there really should be a retraining program so that it can actually be a diagnostic tool and not something that they just go through the motions. MRI has obviously replaced the DRE as to trying to find a nodule. If you felt a nodule, you would send someone quickly for an MRI, which has replaced almost everything else as the thing to go to tell what's going on in the prostate. Yet recently there have been some reports that the error rate with MRI may be as high as 10%. So we obviously don't have a perfect test yet. It's certainly better than anything we've ever had before. And a note, just in general terms, the micro ultrasound, 30 megahertz ultrasound is coming. I'm not sure when, but it will largely replace the MRI eventually. It's a lot less expensive. It'll be pushed back into the office instead of the X-ray department, and it will change, I'm sure, whether HMOs will be reluctant to approve the micro ultrasound as the replacement for the MRI. Most of that work was done at the Cleveland Clinic, and it is in the process of being approved by the FDA. And then they can't quite agree when to stop PSA. Age 75 has always kind of been the round number that people use, but yet if you look at our support groups, several of our men are over 75, and so you really can't just put an age where a PSA is not done anymore. If a man in an informed decision making can decide that he hasn't had any problem up to 75 and he doesn't want to do the PSA anymore, then that's up to him. But that should be a discussion that both the doctor and the patient decide. So what do you do? What should our guys, what should they have done? Well, almost everybody agrees that at age 40, one PSA should be done after informed consent and shared decision making. And the reason you do that is you want to see where you're going. You want to see whether there's an early change. The PSA should be very low, and if it is, you can then move on to the next step. If the PSA is less than 1 at age 50, every 3 to 4 years is indicated to repeat it if there's a family history, or every 5 years if there's no family history. If you have a man that's age 40 and it's between 1 and 3, then it should be done every 3 years. And when they get to age 60, it should be done yearly. Between 1 and 3 is the area in the group of men that should be targeted, if we can use that word again, because they're the ones that seem to have the most chance of having an issue. When to do more tests? Well, PSA density, PSA velocity, and the newer biomarkers are all there. We've known about PSA density for years. You take the PSA and divide it into the size of the prostate. And there's a nomogram. If it's a certain density more than it should be, then you've got an issue that should be further evaluated. The PSA velocity is you simply have, if you have a PSA once a year, you see what the percentage increase has been, and you can then doubling time tells you whether or not you need to have any further testing. And that has been used sparingly, but it's almost as predictive as any other indicator that we have. And then we have a whole slew of biomarkers that some have been shown to be helpful, some are not. Almost none of the health plans have taken to these biomarkers because they're expensive. There's at least 5 of them now. They each do something different. Cleveland Clinic is again leading the way in that. They just had a deal with the big Quest, and you're going to be able to get a cash rate for a biomarker from their clinic that they are using Quest to do the work, and it will be at a cash basis. And it certainly can help decide whether or not you need to have anything done. But for some reason, there was a rush of biomarkers, and there was a rush of things with circulating DNA and circulating RNA, and none of which have been taken into the guidelines as things to do. They're noted as interesting, but need more work. PSA greater than 3, there's no disagreement that an informed consent and shared decision. What does this mean? Well, MRI is a standard of care in both this country and in Europe. It is just simply can't get around it. If it is expensive, that's part of the deal. The multiparametric is certainly preferred, and then the newer the machine and the newer the software, the more preferable the X-ray is. The MRIs that are older can be upgraded with new software. So just because it's a lower Tesla MRI doesn't necessarily mean it's not a good one. If you have a normal MRI, you can really go back to just screening with PSA, and you really don't need to necessarily have a biopsy if your PSA is greater than 3. If it's greater than 10, then I think no matter what the MRI said, a targeted biopsy is indicated. That gray area between 3 and 10, though, can be watched almost its own active surveillance category. And even if you do a PSA in 6 months or 1 year after that, If you have an MRI and you have a PI-RADS, which is how they score the lesions of 1 and 2, then a yearly PSA is indicated. If you have a 4 or 5, you really need to proceed to transperineal targeted fused biopsy, and there's no getting around it. Those are the men that really need the biopsy. There's a lot of discussion about the guys that are right in the middle, and most 3s should be biopsied, especially if they're over 2 centimeters. They can be observed and repeat PSA, but if the PSA changes even a little bit, then they should be biopsied. The reason that they're still hesitant to recommend PI-RAD3 as a biopsy candidate is because about half of them will be Gleason grade 3+3 or Gleason grade 2, and they need just simple active surveillance. Genetic tests, Decipher, Polis, Oncocyte, and there's a 4th one that skips my mind. They're all very, very interesting and new, and the companies would love to have everybody on active surveillance have one. They have shown that some of the testing can help predict whether you're safe to do AS or not. And I think for that reason, almost all of the guidelines suggest that genetic testing's time has come. And in particular, it's come because later on it may be helpful, and its predictive value has been documented, and now it is certainly part of the treatment or the workup. Guidelines are not clear if all AS patients need this, but certainly, the more information you can get, especially the genetic information, is better. The patients that are more informed about what their condition is, the better off you are. PSMA gets a lot of activity or gets a lot of publicity now. It's not currently recommended for active surveillance patients. PSA starts to go up, then that scan should be discussed. There's now a move afoot in Europe, especially to replace the MRI with the PSMA, and the PSMA before a biopsy, because it is just as accurate. And if there's a chance that there's any prostate cancer outside the prostate, it's good to know that early on. One of the considerations is, since PSMA has been on the horizon for the last couple of years, it's always been suspicious why there's such a high recurrence rate with the primary treatment. And the feeling is that the old-fashioned bone scan just simply missed too many early lesions, whereas PSMA is shown to pick up those lesions in most cases. However, the current guidelines all agree it should be done in patients that have more advanced disease, or if they have a recurrence once disease is treated. So PSMA is not currently recommended or approved for active surveillance. If you can talk the health plan into doing it, it's again one more big piece of information that is really valuable. The more you know, the better off you are. But currently the guidelines don't support it. Active surveillance, what is it really? Well, it really means actively watching what's going on. Yearly exams, twice a year PSAs and DREs, a heart-friendly diet. There's no question you can argue whether you should be a vegetarian or not, but what has been shown is that heart-friendly diet is good for the prostate. Passive and cardio exercise, all across the board, passive and cardio exercise helps everybody. It helps when you don't have the disease, it helps when you do have the disease, and it builds reserves in your cardiac muscle that are helpful throughout treatment. Mental issues, cancer, anxiety, probably the least likely to be addressed, but one of the more important issues that we face. What to do with cancer anxiety in a disease that is slow growing, tends to take forever to decide what to do, has lots of tests. You seem to always be waiting for a PSA result or a biopsy result or an X-ray result. But cancer anxiety, between the Zoom sessions and the literature that's available, the group sessions, is something that's very important to address. We have a board member, his first name is Jim. I won't give you his last name, but it's the only Jim we have. And he would say that his wife asked him how he felt one day, and he said, "I feel great." And then she told him, "You should act like it then." You really do need to enjoy the days when things are good, and not get into the cycle of being down and out and depressed and anxious about it. Easier said than done. But when you do feel well, it's really good to get out and do all the things that someone of whatever age group we're at likes to do. There's online counseling. There's lots of support groups available. The thing to remember is just doing something about it doesn't necessarily relieve the anxiety. And certainly, as I mentioned, radical prostatectomy treatments is certainly not a good trade-off for active surveillance just to try and get rid of anxiety. We have to deal with it as best we can, but there's lots of resources available. That's it. I do have one aside. Someone asked me about alcohol. And I don't know why they asked me, but since I have grapevines and I make homemade wine, but I went to my doctor the other day and my doctor said I could have 1 glass of wine a day. The good news is that I have 6 doctors. So I don't feel badly about that habit.
I tell you why they ask you for the wine, Dr. Metzger, because they want to go to your house and they want to drink wine with you.
Yeah, probably.
We had just outside. I don't know if any of you know what Merlot grape is, but it's a very nice red wine.
Merlot.
And it's used mostly as a blending wine, but it stands on its own. But in Glendora, where I have this up in the hills, where I have the vineyard, one year we planted a row of it. We wanted to blend it, and when the grapes got ripe, they all disappeared. And we had a camera out there. I'll be darned if the bear hadn't come and eaten all the Merlot. He didn't eat the Sangiovese. He didn't eat the Cab. And so we thought maybe we'd show him the movie, the one about the guy that didn't like Pinot Noir, the guy that loved Pinot Noir.
Sideways?
Sideways.
Sideways.
Yeah.
The bear didn't see Sideways. No.
I have a question.
Sure.
You have passive and cardio exercise. By passive, you mean weights, strength exercise. Is that right?
Yes, and even more the machines.
Say again?
The machines have shown to be less traumatic. You don't have as many accidents, and they build strength. Twice a week is plenty. Not necessarily lots of weight, but lots of reps. And then any cardio, walking, swimming, bicycling. I like to ride my bike. Which is another whole topic of causes of prostate issue.
Mm-hmm. Yeah. Okay. Thanks.
Yes.
I want to ask you that one thing, Dr. Metzger. You said that you ride in your bike. I have already the radiation, and I'm on the hormone therapy. Actually, right now it's not, because tomorrow I'm going for the angio. But even if the prostate is stayed in, which one they treated for the cancer, I still can ride bike, or I'm harming my prostate?
There's absolutely no evidence that you'll harm your prostate. If it were me, I would wear one of the padded outfits.
Yes.
And certainly there's such a thing as a split seat.
Yes.
I would use a split seat and a padded outfit. I think half the guys that ride bikes like to just put the padded outfit on. I'm not sure.
Thank you very much.
Martin had a question about the PSAs in the UK study where there were 20,000 subjects. Maybe we can get Martin here to kind of clarify what his question was. And are we talking about the one that's coming out? We're going to be releasing a newsletter on May 6th, Saturday after this one. And I wonder if that's what Martin's talking about.
Yes, that's the article.
Okay, so
And
there were actually
fascinating that they could take people and do that much unnecessary treatment and they all signed an informed consent because that's part of the doing a clinical trial. It's just amazing that some of them did catch on to that. Maybe they didn't need to be treated that way, but you couldn't do a test. You couldn't do a study like that today.
I was surprised they could do it then.
They would never approve it. Yeah.
Yeah, that was an interesting study, and the two things that caught me was the randomization of assignment. A lot of people are going to know what we're talking about here because that's going to come out in another 2 Saturdays. But the randomization of that got me, and the mixing of those Gleason scores into the different groups, and that was just very interesting.
Well,
it was over 2,600 subjects. And there wasn't even 2,600. It was more like 1,660 or something like that. And about 80 subjects just left. They left early in the study.
No, but the follow-up rate was amazing, and for some reason it took them a long time to figure out that active surveillance was an acceptable form of treatment or for men that had low-grade Gleason scores. They didn't get into what I wish they would have shown more was the few high-grade ones that they found by accident. It would have been interesting to see where they fit in, but I couldn't tease that out of the study. It's a very complex paper, and it's well worth going over, paragraph by paragraph, because it's going to be discussed. It's been the topic of editorials in almost all the journals that I get, and it's just something you just don't see very often.
The thing that kind of got me was that I think it fell short of saying that prostate cancer isn't all that. Maybe we should concentrate on something else, because we do see some very serious problems with prostate cancer, especially where bone health is concerned.
Yes, and that 40% needs to be where our focus is.
Okay.
And bone health is incredibly important. In the old days, you'd see fractures and all kinds of things. And with the advent of drugs like Zometa and the bone reabsorbing drugs, it's pretty much changed and eliminated most of that.
Yeah, I got a question for you on the PSA standard range and UCSF. All the PSA totals consider the standard range less than 4.00. And you're saying that you should be tested or an MRI, possibly anything over 3.00. Is that correct?
In the rest of the world, it's 3.0.
And apparently not at UCSF.
It's interesting. A lot of the places like Canada that restrict care, don't use a lot of the fancy things, they have a lower threshold of trying to find it. So, go figure. But almost every other place it's 3.0. Scandinavian countries where AS is just the standard of care for almost all of it is 3.0. You'd think you'd find more unnecessary 3+3s at 3.0 than 4.0, but that's for some reason that's what they picked.
Yeah. Okay. Just thought I'd ask.
Yep. We used to let it go up to 10. When I graduated, if you didn't have it over 10, you didn't get anything. So look at how far we've come.
Yeah.
I think Kaiser Permanente, the trigger on that is 4.5.
Yeah. And that's
That's where they.
That's an
pull the pin.
old,
Yeah,
that's an
where they pull-
old, yeah, that's an old study that's based on, but with the new guidelines, somebody challenges that and there really isn't a leg to stand on.
That it should be higher or lower? I'm sorry.
It should be lower.
Lower. Okay.
Yeah.
Okay.
But again, they add in Europe, they add in the shared decision and they tell them what possibilities there are. So the people are making the decision along with the doctor. In our system, it tends to be more dictatorial. And how often have we heard somebody say, well, the doctor said if I didn't like what they said or did what they said, they should go somewhere else. Well, you know, we haven't heard that lately, but we used to hear it quite a bit. As things change and the younger guys come in, I think they're a little bit more adaptable to these newer things. One of the biggest advantages of a oncologist that specializes in prostate disease is they tend to really be a lot more flexible and understanding, and they look at a bigger picture than whether I get to do a radical prostate on somebody or not, or whether I get to radiate them or not. They tend to have the bigger picture, and I think that's probably been the nicest change in our business in a long time. You get somebody that's more interested in the overall picture rather than one small area.
Can you clarify in the early slides, you indicated that the US, whatever standard it was, says no to PSA. Is that still the case?
Yes,
It is still the case, but these guidelines say different. Is that correct?
almost all the other guidelines say differently. Yeah.
Yeah, okay.
And that's a group of more internists, general practitioners, and academic people. So their inclination was a little bit, we don't have the time, we don't have the expertise, we don't know how to do DREs. We don't, nobody knows what to do with the PSA. If it is drawn, we can't spend 20 minutes with a person explaining it. And I think that slant is because of their experience. If you look at the ones that actually are in the trenches with the disease, it almost always tends to be PSA if you understand what you're getting into. And the shared decision making is that word or that phrase appears 100 times in the guidelines because you need to decide what's right for you. If you think you're going to have a heart attack in 3 years, what's the point? And if your family, if you're the oldest living member of your family and you're only 55, you may want to not worry about prostate cancer. You might want to worry about a heart healthy diet and exercise more. So I think the shared decision making is the key to understanding whether or not you should have one done. But it's just fascinating to me that almost every study agrees if at age 60 it's less than 1, you can kiss it goodbye.
But from the point of view then, sorry.
So few aggressive cancers ever come from that group.
Right.
So that probably is one main area that everyone can agree on.
But from the point of view of insurance coverage, these guidelines that say the PSA is worthwhile, they're accepted by the insurance companies and by Medicare.
When the pressure is put, well, Medicare agreed with the United with the Armed Forces group. The Medicare doesn't cover PSAs unless you have an elevated PSA. Isn't that the way to go?
Cart before the horse. Okay.
Yeah, you have to have one, so you get the first one at your cost, and then if it's elevated, they'll cover the rest of it. Let alone a free PSA, which is really a good pre-biopsy indicator. That's even more expensive. The group that from Cleveland Clinic that is going with Quest, they must be discounting that test because that was an $1,800 test when it came out.
Wow.
And you can imagine if they won't pay for a $35 test, who's going to pay for an $1,800 test? And you know, there just aren't that many people real willing to write a check for that if it really doesn't change anything. You're still going to have a certain amount of testing. I do think the big change will be the ultrasound, micro ultrasound. If you can skip the radiology fee and the expense of the MRI, because the new ultrasound will show the targeted lesion, you can get it all back into the urology office, and at the time of the ultrasound, they see the target, they take the biopsy. It just speeds up the entire process. And especially as everyone retrains and learns how to do transperineals and the complication rate goes down, that's going to be a big change, I think. But there's been a big resistance to retraining people. They just don't seem to want to do anything different. And, you know, we bought a machine. Our machine we bought was a $150,000 ultrasound machine. And that was one of the state of the art back in the 2000s. And we milked that machine for 10 years before we had to replace it. But, you know, that's a big expense. And if, you know, how often can you shell out $200,000 because things are changing so fast? But I wouldn't want to have just bought an MRI machine if you're a urologist. And I mentioned before, the guys that got into the radiation business, the machines are so antiquated that they're not even scrap metal. And it's just another big economic wave that's going to change. The centers with the newer ones are going to naturally get the work, and which they should. They're that much better.
Mhm.
We've come a long way.
Quickly.
Yeah. Anyone else have?
Dr. Metzger, did the Great Britain study address anything about testosterone levels?
It did not.
Okay.
Some of their patients got 3 months, and some got 6 months, and some didn't get any. And it was up to the discretion of the country doc. There's going to be a study. It's about halfway through, and it'll be fascinating when it comes out. They're going to compare men that have radical prostatectomies. They're going to do the theranostics before, and they're going to see what effect it had on the prostate and on the lymph nodes that they take out during the surgery. And is there microinvasion in those lymph nodes? What does it do to the prostate cancer? Does it really do what they think it does? And then they're going to compare that to men that are on Lupron and men that take an androgen receptor inhibitor. And they're going to see what effect on the cells and hopefully what effect on the DNA and all the cell components that these different medications that we use, what do they really do? But, you know, that's going to be 2 or 3 years down the line. The preliminary data ought to be fascinating, though. For anyone that's gone through theranostics, sometimes it's very helpful. Sometimes it seems not to work as well. But we really don't know whether the change on the scan means what it means. How much disruption of that lymph node do you need to make it go away? And those are the kind of things that need to be answered.
Everyone, take a look at the chat, and I posted the link to the Active Surveillance Patients International website. And if you go on their website and you scroll down, you'll find the link to register for the Dr. Epstein event. I would recommend it. There's a lot of second opinion biopsies that they do, and not just with prostate cancer. So if you want, check it out. If you have a chance, tell Aspie that you heard about it at Prostate Forum. But check it out in the chat. You can also save the chat, or it should save automatically, but in case it doesn't, that can be saved to your computer, to your documents, simply by clicking on the three dots. The three dots on my computer appear way at the bottom. If you look at the right-hand side across from the smiley piece of paper and the smiley face, you'll see three dots, and you can save the chat, and that'll give you the link to the Epstein event. It's aspatients.org, I believe it is. Yeah, aspatients.org, and just scroll down and register for it there. Any other questions tonight?
Like, no, it's very good. It's very informative. Thank you.
I'd like to add that the NCCN guidelines are at the Prostate Forum website.
Thank you.
So if you want to find it, I think it's under newly diagnosed. Is that where it is?
Yes. Yeah, I got it.
Yeah,
Right.
it's the links to their actual NCCN sites. So you're getting the latest and greatest all the time.
Oh, really? It updates automatically. Good. Good. And by the way, what we have is for the newly diagnosed, which Dr. Metzger talked about. There's also an advanced NCCN guidelines, but that's going to be probably maybe another presentation if somebody else doesn't show up.
Now, there was a question in the chat about ISO-PSA in the Cleveland Clinic. I'm trying to get a 5 to 10 minute talk on that at the next advance meeting from the company that's doing it. But we're trading emails and can't quite come up with the time. But I think we'll have some information about that in the next week or two, right from the horse's mouth.
Right.
The right age to start getting tested for PSA, especially if you suspect that there are BRCA factors. I'm hearing for Black men that age is 45.
They went all the way from 35 in Finland to not doing it at all. If there's a family history and if you have Afro-American ethnicity, I think almost everybody would agree in sometime around age 40, 1 PSA as a baseline should be done. And you could even make a case, because it's such a different disease in that age, in that ethnic group, that at that point they should even have a genetic test. And you could probably predict which ones were going to go on, because not only they have a higher incidence, it gets worse and they don't do as well. So the earlier you know the information, the earlier you can react to it. Unfortunately, the guidelines were all over the place on that particular age group, all the way from 35 to not doing it at all. One of the interesting things in the guidelines is some of the socialist countries, no political lecture here at all, but some of the socialist countries had the earliest age group for detection, which means they're detecting more non-lethal disease and causing a lot more anxiety and medical costs. You'd think it'd be the other way around. They'd want to just put it off until they had to do something. So that's an interesting trend.
Anybody else with a question tonight? Well, I'd like to invite you all to our support groups. Many of you, I see some very familiar faces. We're entirely on Zoom these days, and we're accessible all over the world if you can get to Zoom. We start second Tuesday of the month, 5 p.m. Pacific, fourth Tuesday of the month, 5 p.m. Pacific. Check our website for links And by all means, sign up at prostateforum.org to get our newsletters, to get meeting announcements and other things of interest. That's prostateforum.org is our website. Anything else that anybody would like to add?
Thank you, Doctor.
Well, thank you very much, Dr. Metzger, as always, for many years of bringing us encouraging news to Prostate Forum. I wish you all
Neil,
a
where
good
did you
night.
say, where
I'm
did
sorry,
you
go
say
ahead.
the National Comprehensive Cancer information is? On your website, where?
On the news and events section on the homepage, the second item is the Prostate Cancer Foundation National Cancer Coalition Network have published updated guidelines. There's 2 links there.
Okay.
In the meantime, in 2 Saturdays, you'll see Dr. Metzger's newsletter on the UK study. Very, very interesting. Anything else, folks? Save the chat and have a great night.
Really